We're going to move on now to the child's focused themes, and the first speaker will be Dr. Omendra Narayan from Royal Manchester Children's Hospital, who's going to speak to us about the common problem of managing respiratory problems in children with esophageal atresia. You're very welcome.
Thank you. And thank you very much for inviting me. And I must say that I was just talking to Sue that one of the talks that I was hearing from one of the parents, she might be here, and it was very powerful, and it was quite emotional as well. And we always feel that, like, you know, having the parental engagement, and we learn so much from parents. And particularly when we are talking about something which is not like common cough and cold and pneumonia, which we are very well used to. When we're talking about TOF and OA, it's still a rarer kind of condition, and in many circumstances I feel that definitely parents know much more than medical professionals, and we get to learn a lot from them. And definitely when I was a junior doctor, I had no idea about like what OA is and what TOF is and what kind of problem we are expecting, what a normal X-ray looks like, what an abnormal X-ray looks like. So I have learned a lot from our kids and from parents. So I think I heard the talk from the physio session as well, and that was amazing. And I think that she has already done half of my talk, so that makes my job really easy, and so we can have a revision now. So what I'm kind of, in next 20 minutes or so, I'll speak, and then next 10 minutes we can ask questions. So I don't need to go through medical classification of OA and TOF, and by this time you would have known a lot about, there are various forms of OA and TOF. I'm told that the internet doesn't work, but basically on the YouTube, if you search on YouTube, there's a good video about talking about OA and TOF, and also how we do surgical repair. And the reason I wanted to show that video was because essentially, if we understand the embryology, how the gut is formed and how our respiratory tract is formed, it becomes easier to understand what OA is and what TOF is. Because in the embryo, from one egg, by the time we are around 4 weeks, it forms a kind of a tubular structure. And from that tubular structure, the lungs will come out. And if there is a problem somewhere in that pathway, then we can have defect of your feeding tube and your breathing tube, and which is essentially what our OA and TOF is. So I am going to talk about mainly 4 common things that as a respiratory pediatrician we see. We at Manchester Children's Hospital, where I work, and you will hear the next talk from my colleague, Mr. Lansdale, we were trying for a long time to have an MDT clinic for these children. And after kind of various years of fighting with management and everyone, we have successfully kind of established a clinic last year. So we are really pleased about that, but it's still not very MDT, which we would like. So we have a very experienced dietitian, and we run it with surgeons and us respiratory pediatricians. So we are kind of seeing and trying to make it more cohesive so that we can approach these children in a much better way and we can give the best output. So what I'm going to talk about is that mainly tracheomalacia, which if you were in the workshop, you would have heard, but I'll just talk a bit more about that. Then we'll talk about aspiration, and I'll explain what that means. reflux, even if in the medical advisory meeting, we were talking about reflux and what happens. So I'll just touch upon there. And then kind of in the end, we'll talk about what reactive airways is and what we mean by that. So this slide was shown in the physio session. And essentially, when we talk about tracheomalacia, by trachea is your windpipe, malacia is weakness. And the commonest example that I use in my clinic when I'm explaining what tracheomalacia is, I use the example of our ears. And that's what I had learned from my bosses. So trachea, which is windpipe, is cartilaginous on the anterior side. So more than half of its structure should be cartilage, which is like the top part of your ear, stiff. It should be stiff. But if there is any problem in the development of that cartilage, it's soft, like the bottom part of your ear. So that's what tracheomalacia is. If it is, instead of being stiff, if it is soft, then instead of being this structure, what we show over here, that being like stiff like this, it goes floppier, it goes flatter. And that effect is much more when we are breathing out rather than when we are breathing in. So that's kind of some images over there we can see. So that's kind of your major problem. But sometimes we also see that there is what we call as posterior kind of tracheomalacia. So this end, so this is your cartilage, C-shaped or U-shaped, depending upon what age we are talking about. But this part is your muscle. And sometimes there is a bit of bulging of muscle inside, what we call as posterior tracheomalacia. So you can see majority of times there is a problem in the cartilage, and by the nature of it, almost all children will have tracheomalacia, because by the nature of defect, which we were showing over here in this kind of first slide, because if it is attached over here, the blind end, and when we repair, there is always some floppiness over there. There is always some floppiness there. So all children will have tracheomalacia. But it's a very wide spectrum. And that's what we need to remember. That some children will have just a very, very minimal malacia, some TOF cough, without having any problems in their life. But some children will end up having those death spells, which we will talk about. So that's what our tracheomalacia is. If we do a bronchoscopy, so bronchoscopy is a camera test which you can do in two different ways. This is a rigid camera test which is done by our ENT consultants. We use a flexible scope. So we are just going in, and that's kind of the front of your breathing tube, the vocal cords. So over here, these are our two vocal cords. We have gone inside now. Now you can see the flattening of your tube, and this is what we see. And there are classifications of mild, moderate, severe, but you can see over here that it's really, really we have just passed the site where it was repaired. That's your now carina dividing into right and left, and you can see that actually the weakness is not just there in this particular case, the weakness is also further down. I think probably this is much better now. I can play the video again. It's only 30 seconds.
For the cameras, we can't see the lights.
Oh, right, okay. So I'll just play it again. So kind of, because this is important, because this is all what malacia is. So we are going in, vocal cords over there, and as we go, this is one of our common patients, which we have seen the video several times. So repair site, and then we go inside. So you see that it's really kind of squashing in. And what we need to, so left and right, and even further down, it's squashed in. So if your weakness is in your windpipe, which is trachea, weakness, malacia is tracheomalacia. If the weakness or floppiness is further down, depending upon left or right, it's your bronchomalacia. Bronchus is the lower down breathing tube, malacia is weakness. So depending upon where the weakness is, the presentation will be accordingly varied. So This slide is again kind of, there is a cartoon video. I've taken this from cystic fibrosis kids, but essentially what I want to show what happens if there is malacia, because there is ineffective mucociliary clearance. So essentially what we are saying is that we don't clear the secretions very well. So this cartoon on this side, this is a normal mucus, and the one on the other side is showing when it is defective. So what I want to show is that if you compare two videos together, and so this is like your good ciliary movement, which is like hair like brush, coordinated movement, and on top you're seeing secretions, green bit, and flowing really nicely. Here on this side, not a good movement, and all the mucus is just getting stuck. I'll show it again because it's hard to kind of just keep looking. It should be in the loop, so if it is playing. Is that kind of clear? So we have talked about tracheomalacia, which is floppiness, weakness, flattening, and then ineffective clearing of those secretions. So we are talking about a flattened tube and which is not clearing your secretions very well. So what happens because of that? So if that is happening, then it can present in different ways. And as I said, it's a massive spectrum. The worst spectrum being that they are going blue when they are just born. So post repair, whatever you do, so majority of these children will require ventilatory support, but you should be able to slowly wean down the support from the breathing machine. But if you are unable to wean down the breathing support, then you start suspecting that this child might have severe malacia. And that's why they're requiring some positive pressure to keep these tubes open. Sometimes when they're crying, as you can imagine, when you're crying, that flow becomes more turbulent, and as we were seeing in the physio session, it collapses further. And that's what happened, that sometimes on handling, on crying, these children, they just go blue. And you might have to bag them, give them extra oxygen, give them extra pressures to just try to keep their airways open so that further oxygen goes down. But on minor spectrum, they might just have just a cough, which I'm sure you all are used to listening and knowing that we call it commonly as TOF cough. So it can depend, like it can vary from cough to death spells. But majority of children, they will have recurrent infections, particularly when they are young, because your tube is smaller in size and floppier as well. So we have seen that they don't clear the secretions very well. And if you're not clearing the secretions very well, these secretions are a very, very good medium for all the bacteria to kind of grow really nicely. So when you are younger, when the tube is a bit floppier, you are more prone for getting recurrent chest infections. As you grow older, the size of the tube gets bigger, so the malacia can get better. So even if the malacia is there, just by the sheer size of the tube, you clear the secretions well and you manage it really well. So what we are talking about is in the first few years, it can be hard in terms of breathing just because we don't clear effectively the secretions. So how do we manage it? What do we do assessment? So I think this is where kind of I find really tricky, and I'm sure that we have some GPs as well in audience, because parents will be able to appreciate the nature of cough. They know their child very well. So they know if the cough has changed. And that's what we want to know. Because the child will have a baseline cough, which we are saying TOF cough. But if the nature of the cough has changed, we feel that there is lots and lots of secretions, even if the chest is clear, which majority of time the chest will be clear. Because if you take your child to the doctor and they say chest is clear, which majority of times it will be, what we are saying is that we should have a slightly lower threshold in terms of starting early initiation of antibiotics. And that's what it's all about. I know that we don't want to use antibiotics a lot, and rightly so, because we don't want resistance in the long term. But when they are younger, and if you feel that there is lots and lots of secretions and the nature of cough has changed, then that's the time we might have to think about, do they need a course of antibiotics? And one of the crucial things that we always ask, in fact, my 5-year-old daughter has learned, because I asked so many times, is it a dry cough or a wet cough? Dry cough or a wet cough? So even when she starts coughing, she asks me, Dad, is this a dry cough or a wet cough? So that's my first question that I always ask. Is it a dry cough or a wet cough? And if it is a wet cough and it's persistent, then I want to know a bit more, and I will have a slightly lower threshold of starting early antibiotics. So, and again, kind of if you present in casualty, A&E, ED department, again, junior doctors, first assessment, they might not be able to appreciate that the child might be clinically well, saturation might be normal, and chest might be clear on auscultation. So, I was in Madrid last weekend and until Wednesday attending ERS conference, which is our biggest kind of society's conference. And the task force has come with a statement on managing tracheobronchomalacia. Good bedtime reading for you, 96 pages. If you want to read on management of tracheobronchomalacia, quite a lot on over there. But essentially, when we are talking from us, the vast majority is conservative management, physiotherapy, and antibiotics. So, physiotherapy I'm not going to talk about. I'm sure you have learned a lot in the workshop. There are various techniques depending upon the age of the child. There are various devices which we can use in terms of their airway clearance. Someone was asking, should they be asking for physiotherapy? If you're kind of consultant, they think that there is significant tracheomalacia, then physiotherapy is key. And even if you're not doing every day, a child, when they get viral infections, they will have more secretions. That's the time you should definitely initiate physiotherapy. So if you have not been taught, or if the physiotherapy has not been engaged, something you can ask to your clinicians at your center, that do you think my child has significant tracheomalacia? If you think that there is significant tracheomalacia, then physio should be integral to their management. So something to take home from today. So couple of things that task force has mentioned and which we don't do that often in children, and sometimes they talk about stents. And so if the concept is that if there is a segment of your windpipe which is a bit floppier, can we put a stent which will keep it open? So stents are of different types, and because the task force talks in almost 10 pages about different stents, and certain centers in Europe, they are quite active in putting stents. In UK, we are not that keen on stents. And the reason being, because with our limited experience, we have seen few complications happening in long term. Some of the stents are biodegradable, so in 3 to 6 months' time, they will degrade without any removal. But we know that majority of children, they don't have problems, and children who have problems with tracheomalacia, the problem is much longer rather than just 3 months' time. So we don't often use stents if you come across talking about stents. So surgical management, I heard that someone mentioned in morning that their child has had aortopexies. So I'm sure Nick is sitting here, he can explain better than me, but essentially in aortopexy what we do, so this is a cartoon over here, and so this is your windpipe, that's your major blood vessels coming out from the heart, and this is your aorta, the red one. So essentially you can see that there are blood vessels coming out from your major blood vessel over here, and it's crossing your windpipe. So if there is some floppiness over here, what in aortopexy they do is that they will lift this main blood vessel and bring it forward and have a stitch with the sternum, with the breastbone. So essentially what you're giving is that giving some space for this trachea so that it's not floppier anymore. So you just give more space for trachea to be not go floppy with the effect of your major blood vessel. So that's kind of, we use it, so aortopexy is used commonly all over UK, but we only use it if we think that your floppiness is restricted to a certain part. But in the video that I shown you, you could see that the floppiness or the weakness was not restricted to one part, but was going further down as well. So in those cases, the effect of aortopexy is limited. Now, recently, in kind of last couple of years, something called as posterior repair has come quite rapidly and some of the UK centers have started doing it as well, which we haven't done yet, but probably we might start doing it sometime in future. And I recorded one of the videos from ERS in, you have done, so Nick tells me that we have started doing it now. So I kind of recorded this video on my phone when I was listening to one of the surgeons at ERS, an Italian surgeon, just showing. So this is again the cartoon of that, what we are showing over here, and that's your esophagus, and just behind that. So this is your trachea. Essentially what they're doing is that if you're trying to repair the posterior part, if you remember that the muscles which go behind, what they're trying, so this is esophagus, just removing it there, remove the esophagus, they can see the trachea, they'll put a bronchoscope camera inside so that you can see where they're taking the stitches. So trachea, esophagus, and they're stitching it at the spine. Instead of sternum, they are going behind and stitching it over there. And so they have put the camera inside, so this is your trachea, they can see where they are going, and this is the bronchoscopic image from the camera, what they're seeing. So they can take stitches, they know where they are taking the stitches. So, do you think, Nick, this will become much more common?
Yeah, I mean, I'll touch on it later, but the difficulty is knowing when you want to go to the time of the esophageal repair and knowing which
babies, yeah.
It lends itself really well to delayed primary repairs where you've just taken the fistula at the first sitting and then a few months later you go back to do the joint. You can do it then in the ventilation, which we've done twice in very small babies.
Yeah.
Premature babies.
So probably something that will come in future and will get much more better in that. This is the kind of the most severe spectrum that if we have tried or we think that it's not suitable enough in terms of aortopexy, tracheoplasty, posterior repair, then some of these children will end up getting, and if they're having lots and lots of those blue cyanotic episodes, they will end up getting a tracheostomy. And the tracheostomy is because you want to keep them safe, you want to have a patent airway so that always they can breathe in and breathe out. But sometimes one of the limitation is that once you give them a tracheostomy, which is a tube, it's an artificial tube in your breathing windpipe, then sometimes they will require some positive pressure as well, what we call as long-term ventilation. Some of these children will require, in the first few years of life, some positive pressures to go home. The numbers are extremely small. Rarely these children will require long-term ventilation, but they do require. Some of these children, they will end up on tracheostomy and long-term ventilation. So that's kind of one of the major problems with these children who are having malasias. Second thing, so as I said, I'm going to talk about 4 things, but that was my more than half of the talk. So don't think that 4 things are that kind of big. So aspiration is the second thing, and the reason why they aspirate can be kind of several reasons for that. What we need to remember that many of these children will have problems with the motility of their esophagus. So by aspiration, what we mean, so this is a cartoon showing over here, that normally what you expect, because your windpipe and the food pipe, they're just sitting behind each other. So you expect that once you eat, the food should go in your food pipe, but sometimes they choke and the food or liquid or milk, fluid, water, anything will go into your windpipe as well. And that's what aspiration is. And some of these children, they aspirate recurrently. Our windpipe and lungs are meant for air, not for any fluid, liquid. If the liquid or fluid, any food is going continuously in your lungs, then you can develop aspiration pneumonitis, like pneumonia-like picture in acute problems, or in long term, you can develop scarring of your lungs, which is not a good news. So if we are worried about aspiration, then we need to think about how to treat them. So as I said, the cause can be several. Some of these children can have a hole in their larynx, in the voice box, and that's why they are doing it. And that's not kind of, as I said, because the defect itself is in the, when the food pipe and the windpipe is being formed, some of these children will have underlying problems of laryngeal cleft. Swallowing problems, very, very common, and I'm sure Nick will talk about that. We have talked about, because the way it is repaired, these children will have reflux. And the reflux could not be only just acidic, but it could be non-acidic reflux as well. And again, reflux itself is a very, very wide spectrum. Some of them are extremely mild, don't need any treatment, but some of these children with reflux will end up aspirating as well. So some liquid coming up and just trickling over in their windpipe. So again, thinking about, is that reflux? Is there something else? So if we are worried about the chest, that they are having recurrent chestiness, recurrent problems, then we are thinking about, could they be aspirating? And if they have abnormal esophageal stricture because of dysmotility or poor motility of your esophagus, essentially they can have pooling of secretions. They're not clearing the secretions very well, and if they have those secretions in their gullet, some of these will trickle over in their windpipe. And if they are trickling over, then again, they can aspirate. So I've already talked about essentially on the lungs, when this is X-ray and there's a CT scan which we are cutting like this across. So on our lungs, on the X-ray, air appears as black. Any fluid or bone, they appear white. So that's in center our heart, that's our spine. These are left and right lungs, but you can see that lots and lots of whitish shadow which you see on the X-ray, and when you end up doing a CT scan, you can see that the breathing tubes have become more dilated, and there are lots and lots of permanent changes, which is essentially scarring of the lungs. And that's what we are trying to avoid, because the scarring of the lungs can become irreversible, and they might need recurrent hospitalization in adult life, which we are trying to prevent. Coming to third problem, so we talk about reactive airways and wheeze. So some of these children will be wheezy. And the reason for being wheezy could be, like, again, different. So many times parents will say that the chest is rattly, and so they are secretions. And there are various terms like kind of local slangs for all these rattles and chestiness. So sometimes the secretion itself, we have seen in the first slide about malacia. So if you are malasic, if the breathing tube is a bit floppy, then you retain secretions, and those secretions itself will lead to rattles and chestiness and wheeziness. Again, if you get lots of infections, particularly with viral infections when they are younger, and we are talking about small breathing tubes. If you get, so this is on this side, you can see your normal breathing tube, good caliber where air will flow in and flow out. When they get viral infections, then they can have a bit of swelling in those muscles over there, leading to narrowing of your tubes. And if the tube becomes narrow, the airflow becomes more turbulent, giving rise to wheeze. But we need to remember that some of these children can actually have asthma as well. So regardless of their underlying problem, some of these children could, because we know that roughly 5% of UK children will have asthma. So some of these children could be asthmatic. And the presentation could be, again, similar, with wheeziness, shortness of breath on exertion, exercise-induced breathlessness. So that can be your normal presentation. But the management depends on what exactly is the underlying problem. So these things, again, kind of I have put over there that there are hundreds of inhalers in the market. Sometimes we are a bit cautious by using the blue inhaler. Your doctor might have said that just be cautious with the blue inhaler because we don't, in children who have malacia, floppiness, there is a risk that if the muscles get more relaxed with the blue inhaler, your breathlessness or wheeziness can get worse. And so we are a bit cautious using the blue inhaler, but essentially some of these inhalers reduce the swelling of your muscles, making the airway a bit bigger. Physio we have talked about, antibiotics we have touched upon. So some of these children, particularly when they are younger and they are getting recurrent infections, they have significant malacia, then we might have to leave them on preventative antibiotic during the winter period. We might see that for 6 months in the first year or second year of their life, we might have to leave them just 3 times a week or once a day of antibiotic. I cannot emphasize enough on avoiding passive smoking. If you have any lung problem, airway problems, even if parents are smoking, that's having a very, very harmful effect on the child. So extremely important that you don't smoke, even if you're smoking outside. None of our parents smoke inside. They all say they smoke outside. It's a problem. So if you're smoking, definitely recommend. So coming to my last couple of slides, as some of these children will have recurrent viral infection, upper respiratory tract infections, they can get chest infection like any other children, but we have talked about that they can get slightly more in terms of numbers when we are talking about antibiotics. So as I said, some of these children will end up having preventative or prophylactic antibiotics. We tend to give slightly longer course of antibiotics as well. The reason being because if you get pneumonia or I get pneumonia, 5 days of antibiotics is fine, absolutely fine. But as we have seen, some of these children will have problems in clearing the secretions. So they need slightly longer course. And we generally recommend 10 to 14 days of antibiotics. So if your GP is prescribing antibiotic, we will also ask for a longer course. So yeah, this is kind of my probably last slide. So we have talked about kind of recognizing that there could be problems. It could be malacia, aspiration, reactive airways, or chestiness. Some of these children will need physiotherapy, preventative antibiotics, and not to forget their childhood vaccination. And that should include flu vaccine during winter month. And we generally recommend that all family should ask for flu vaccine in winter. That's my summary. Thank you.